Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of February 10th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. Before getting into our update, I wanted to briefly touch on some of the health advertising that occurred this past weekend during the Super Bowl. There were actually quite a number of different advertisements regarding health, from cancer to hospitals to pharmaceuticals. But in particular, there's one I wanted to comment on, which was a company called Hims and Hers. And it was sort of a bizarre ad because it started off by basically criticizing Americans for being overweight and then criticizing the American healthcare system for profiting off of it, but then going on to promote their own weight loss medication. So this definitely piqued my interest. We've talked about the class of medications called GLP-1 agonists here on the briefing a number of times, which are medications for diabetes, but also are being used for weight loss. And these include medications like Ozempic and Wegovy. So I looked into the company, and it turns out that this is actually a telehealth company that is offering its own version of these GLP-1 agonist medications that they are apparently compounding themselves. And I came to find out that the commercial that aired during the Super Bowl was actually released at the end of January, and it sparked quite a lot of concern. In particular, a couple of senators tried to get the FDA to intervene, and I've linked their letter in the post in case you're interested. But their biggest concern was really around the fact that we know that when pharmaceutical companies advertise directly to consumers, they have to disclose the risks and the side effects. That's why at the end of all those commercials, there's that rattling off of all the different side effects and safety information on the medication. But in this case, the commercial did not include any of that. So the senators were basically or are asking the FDA to take a look and take action because the advertisement is therefore misleading. And this is not consistent with what we require of pharmaceutical companies. So they basically say that if there is some kind of a loophole that's allowing this to happen, that the gap should be closed. So they're going to introduce some legislation about that. So it'll definitely be interesting to see how the FDA responds to this and other concerns under this new administration. But it is a little curious that at the same time that we seem to have a pause in public health communication, we are also seeing what amounts to a relaxation of requirements by those who are profiting from selling medications. So I'm sure that there'll be more to come on this in the future. So let's dive in now to our update on communicable diseases. So from what we can see here, taking a look at the percentage of tests for respiratory viruses that are positive from each of these different causes, we can see that bright blue line, which is influenza, really just keeps on heading up, and it doesn't appear to be slowing down, unfortunately. We can see some slight increases also in the common cold viruses in the orange, as well as human metapneumovirus in black at the bottom there, and adenovirus also at the bottom there in light blue. Those lines are going up slightly. I know it's difficult to see with so many lines here, but they really don't let us separate them individually on this graph very easily. RSV in the green line and COVID in the red are both heading down ever so slightly, so that is good news. This is showing us through February 1st. So taking a look at ER visits, not a surprise to see here that the percentage of emergency department visits for flu are also heading straight up. RSV and COVID are making up comparably lower shares of emergency department visits, so they're heading down a bit. This is also showing us through February 1st. So pretty nice and updated, which is a good thing given all the concerns about the different pauses in information. When we take a look at hospitalizations, these are the more severe folks. And again, through February 1st, we're seeing the same thing, flu continuing to head up without any slowing down in sight. When we take a look at deaths, we can see that deaths from all three of these viruses are continuing to increase. So all of that orange there is COVID, all of that blue is the flu, and then the RSV is in purple. So for the first time in quite a while, for that week ending January 25th, one to the furthest right, this is the first time in quite a while that we're seeing that COVID deaths and flu deaths are actually making up the same percentage of deaths. And so at least since this graph was started, which was in October of 2023, this is the first week that we are seeing this happen. And so we'll have to see how the rest of the flu season goes, but we will anticipate that it may go up before it comes back down. When it comes back down, it'll be next to nothing in terms of flu deaths, while COVID will continue year round. So that's basically what is expected, but we'll have to keep an eye and see. And speaking about COVID continuing all year round, we can see that when we look at COVID in the wastewater, that unfortunately it's increasing nationwide and in each of the 4 US regions. So even though we're seeing cases and emergency department visits decline as a percentage of the overall, the wastewater, the amount of the virus that's actually circulating in the wastewater is already heading back up. This is also showing us as of February 1. And we know that wastewater is our earliest indicator. So after wastewater goes up is when we expect the other things to go up, like emergency department visits and hospitalizations and deaths. So just something we'll need to watch. But of course, this would not be out of the ordinary for SARS-CoV-2 at all, where we know that we may get a reprieve or a lull for a little while, but that only lasts for so long. And there is still quite a bit of SARS-CoV-2 circulating around in our environment, even though it's currently also coexisting with flu, RSV, and a number of other things. Now, taking a look at COVID deaths, of course, this continues to be a very troublesome fact that we continue to lose so many people to COVID. And now we are up to 940 deaths for the week ending January 11th. And of course, part of the reason why this continues to be so troubling is that it's not just once a year that we're getting these big numbers, as is the case with the flu. So we're close to 1,000 deaths in just 1 week now. But remember, even just this past summer, it was pretty much the entire months of August and September where we were well over 1,000 deaths every single week. And then all the other weeks in between, we're still seeing 500, 600, 700 deaths per week. So this is a very, very high burden that when you look at it over the span of the year, really does overshadow all of the deaths from the other illnesses that are transmitted by airborne particles. So we clearly have a lot of work to do here still. On the individual level, that looks like making sure that we're preventing the spread in all of the ways that we know how to do that, like masking and improving indoor ventilation, staying home when you're sick. Also, very important, making sure that everyone who is at greater risk of a bad outcome is getting the updated vaccination, also getting timely testing and treatment if they are positive. And remember, if someone decided not to get vaccinated, then it means it's even more important that they get timely tested and treated. So let's not just assume that because someone didn't want a vaccine that they won't want life-saving treatment. In fact, it should be, or it oftentimes is quite the contrary. And so we're going to want to make sure to keep that same messaging going, that timely testing and treatment does prevent hospitalization. It does prevent death. So this might mean each of us thinking about who in our life may fall into these categories of folks that even if they decide not to get the vaccine or not to go for it, at least you'll know that you've done your part. And who knows, you really might remind someone of something that they've just forgotten about, they haven't been thinking about because you're not constantly hearing about it anymore, or they may not even realize that it's important anymore to get an updated vaccine, or they might not think that outpatient treatment is still available to them, but it definitely should be. So just something to think about. And on a system level or on the population level, I think we are going to ultimately need better vaccines. And until we get better vaccines, we're probably going to need to protect many more folks with the twice yearly vaccines. Remember, the folks 65 and up, as well as those with immunocompromising conditions, are recommended to get the COVID vaccine twice a year, every 6 months. So we're going to have to make sure we're getting that message out there a little bit better. And we're definitely going to have to do better as it relates to improving indoor air quality. And I will talk a bit more about that later. First, I wanted to address the pause in health communications that was put in place by the new administration. And one of the things I talked about recently was the fact that this pause included putting a pause on the Morbidity and Mortality Weekly Report, or MMWR, which has been reliably weekly reporting for the past 60 or 70 years. And we know that when this pause occurred, that there were 3 reports that were apparently scheduled to come out on H5N1. And those were supposed to come out in late January, but they did not come out. So we waited. And so where we are right now is kind of a good news, bad news situation. The good news is that the MMWR did resume reporting on February 6th. So I know this font is small, but I was really just trying to show that this was weekly before. It came out on January 9th, came out January 16th, came out every week before that. But then for the first time in 60 or 70 years, there was that 2-week break right there where nothing happened. And then on February 6th, we got 2 MMWR reports. So that's kind of the good news, kind of. So the bad news is that, first of all, none of the reports are on H5N1, which I think many of us would agree is among the most concerning looming health threats that we are watching unfold before our eyes, but no H5N1 update. Secondly, these 2 reports are what are called notes from the field, and they are regarding the wildfires in Hawaii and in Los Angeles. So certainly incredibly tragic events that occurred that still we are recovering from, and people in those areas are certainly recovering from. So in no way am I downplaying the events nor the health threats that are posed by wildfires. And maybe that's something that we'll review in a future briefing. But what I wanted to point out is that this format, Notes from the Field, is pretty much the least thorough, rigorous, and the least kind of consequential out of all the types of CDC and MMWR reports. So what do I mean by that? Well, here you can see the 5 types of reports that come out of the MMWR. And these are reports that we certainly do rely on. Full reports are looking at issues of high public health importance and guiding practice. Outbreak reports are going to tell us about important outbreaks and what actions were taken. Policy notes are there to announce official CDC policies or recommendations. And vital signs are about important health threats and what can be done to reduce or eliminate those health threats. And last but not least are notes from the field. And these really are brief reports about ongoing or recent events of concern. They can contain unconfirmed information or preliminary results, typically incomplete information with no definitive conclusions. So kind of the most lightweight out of all of the MMWR reports, which feels pretty concerning given the fact that we have a virus circulating widely, obviously a virus with pandemic potential, and apparently at least 3 reports on this virus that were supposed to have already been shared weeks ago, and they haven't been. And instead, here we are releasing notes from the field about events that are in the past. Again, not discounting the importance of looking at their impact. And certainly we need to be looking at how to prevent these things in the future. Not sure to what extent that's really a public health intervention, but nonetheless, I think we've got bigger fish to fry, as they say. So, and not only that, but I look back over a year of MMWR reports, and this is literally the first time in at least that amount of time where there was a week that went by with only notes from the field. So at this point, these are just my observations. I'm doing my best to reserve judgment here, but it is difficult to not be concerned that we're entering into an era of health information censorship and withholding of data. So we're going to give it some time. We're going to hope for the best. I think we'll also be wise to prepare for the worst. So there are definitely folks out there who have archived information from the past, things that have been taken down or what we don't know, permanently or temporarily taken down. We know that there are others who are collecting their own data, whether it be in their institutions or their labs and so forth. We know that there are definitely state level and county level data sources as well. So we'll continue to look for those additional sources. We will continue reporting on what's available and what's missing. But I think it would be fair to say that these are very unusual times we're in. And if we were hoping to improve trust and reduce skepticism, this does not seem to bode well for those goals. So we'll certainly continue to do what we can from our perspective and really hope that what appears to be a dangerous precedent of withholding critical information does not continue for too much longer. So with all of that being said, we do not have an official CDC update on H5N1 status at this time, but we do see that things are occurring, and that it's mostly thanks to reporting at the state level, as well as from other agencies like USDA, US Department of Agriculture. So a couple things have popped up here lately. One of them has to do with outbreaks among cattle in the state of Nevada. And unfortunately, what they have found on 6 different cattle farms is a variant of H5N1 called D1.1. And this is different from what we've been seeing on dairy farms since last year, which is the B3.13 strain. So there are a few reasons in particular why we are concerned about this. The first reason is that up until now, we had only seen this D1.1 mutation really in wild birds. And then we had a couple of severe human cases. You might recall the 13-year-old girl in Canada who spent many weeks in the ICU receiving life-saving measures, as well as the man in Louisiana who recently died. Both of those patients had this strain of H5N1, the D1.1 strain, and it was thought to have possibly mutated and evolved within those patients. But we don't know because we did not know for sure what the exposure was in the girl, and we do not have anything else definitive about the bird that infected the man in Louisiana. It does turn out that the D1.1 strain has infected other people who did not get as sick, so that is good. Not every single person who gets this mutation gets very, very sick, but nonetheless, the 2 sickest people did have the D1.1, and by far the majority of people being infected by H5N1 are having the B3.13 strain. So the numbers are very small. We still can't really make a big pattern out of this or anything, just making our observations at this point. The other problem is that we had not been detecting D1.1 in cows before. So this was a strain that we were only seeing in wild birds. So it does appear that we now have a new spillover from wild birds to cows of the D1.1 variant. Remember, a spillover event refers to a virus basically becoming viable in a population where it was not previously spreading. And we really want to avoid spillovers because this is where we see the greatest risk for a widespread pandemic. We might remember a different recent pandemic that was as a result of a spillover. So that's another issue. And yet another problem with this D1.1 is, so not only has it jumped from wild birds to cows, but also the mutation itself seems to make it easier for the virus to replicate inside of mammal cells, including that it makes it easier, seemingly, to replicate inside of human cells. So the departments of agriculture seem to be doing their part to quarantine the cows and monitor the milk, but it's really not clear how helpful this is going to actually be, because like I mentioned, this didn't come from other cows. This appears to have come from wild birds, which we do not have any control over. So I'm going to talk more about this in a moment, but first for the headlines coming out of New York. So in New York, the governor issued a public health order to close live bird markets after cases of bird flu were detected in 7 different markets in Queens, Brooklyn, and the Bronx in just the past week. And this order goes for all live bird markets in the state of New York. They are ordered to remove all the live birds, conduct a thorough cleaning and disinfection of their facilities, whether or not they had bird flu detected. Not clear how effective that would be. And then they've got to confirm that they are free of H5N1 before reopening. Now, there are live bird markets all over the country, and it's not clear to me what level of testing is really going on. I would imagine that maybe it varies from state to state. But I think the common theme between the live bird market issue and the cows getting the new strain of H5N1 issue is wild birds. So I'm now learning more than I ever thought I would need to learn about wild birds, their migration. Very broadly speaking, there are general pathways that are used by migrating birds. These are called flyways, and different kind of birds may be found in the different flyways. And so it does appear that the birds that were migrating in the North American flyway is what brought the D1.1 variant to the cows in Nevada. And it also seems fairly likely that the wild birds are because of the H5N1 in the bird markets as well. So it appears that the migration of wild birds is at the very least adding to the progression of our current situation, and it's not something that we really have control over. So the good news is that so far we still don't have any human-to-human transmission, and that is very good news so far. But quite honestly, it doesn't seem like we're doing a whole lot to prevent getting from that place. So we're kind of just leaving it up to the virus and the birds and so on. At least that's what I'm currently left to believe in the absence of any other information, which we already discussed is not exactly being shared. So none of this is particularly reassuring, but this is how it seems to be unfolding. But for the moment, let's remember that the more immediate risk that we are facing is from regular old flu, influenza A, which is really causing us significant trouble nationwide. So far this flu season, we've already had over 24 million flu illnesses, 310,000 flu hospitalizations, 13,000 flu deaths, and unfortunately, 57 of those are among children. And this is just so far. We're still very much in flu season. We don't appear to have reached the peak. And even when we do reach the peak, that means that we've still got the whole way down from that peak. So we still do have a ways to go in this flu season. We've already reviewed the fact that cases are increasing, emergency department visits and hospitalizations and deaths are all increasing from the flu at this moment. But what I wanted to just touch on here is the fact that we are seeing school closures across the country due to the flu. And it's been several states, several school districts. It's definitely worrisome. But it also really begs the question around, well, it begs a number of questions. First of all, what criteria are we really using to determine whether it is safe enough for children to be in school? There's just not seeming to be enough transparency, in my opinion, about how these decisions are being made, because we know full well that there are times when COVID has had more people out sick, yet the schools did not close, seemingly due to more of an emotional reaction about closing. So even though SARS-CoV-2 is orders of magnitude more contagious than flu, it's spread much more readily even before people have symptoms, which is part of the problem and part of the reason why COVID outbreaks tend to be much more widespread. So how are decisions being made? And so because we're getting the information from the media and not from CDC, it is a little difficult to say what exactly is at play here. But I just wanted to make a few comments about it anyway. First off, there were reports of a few school districts that reported that they converted to remote learning. This is commendable. So I just wanted to take a moment to say that. Way too many school districts have completely abandoned any of the infrastructure and capabilities that they established in the early years of the pandemic in, I guess, some kind of effort to so-called go back to normal. But the fact is that our normal includes outbreaks, and it includes preventable illnesses that are transmitted through viral airborne particles. And it should include being smarter about it as we learn more. So kudos to those who maintain this option, and just a note of encouragement to others. It can be done and it should be done. I know nobody likes it. It reminds us of a very difficult time, but the emotional reaction that it seems to elicit should not be a reason to not do what is best for our students, both for their health and for their learning, not to mention the health of our teachers, our administrators, our staff, and so on. So the next thing I want to say is something I suspect, and I don't know because again, there's no transparency on the data or how these decisions are being made, but I suspect that encouraging teachers and students to mask during this time would be immensely helpful to the overall school community and the ability to keep schools open. So why aren't we doing it? Once again, we are abandoning things that we previously put in place, and frankly, we are abandoning logic. We can see when cases are beginning to go up. We can see when students and teachers are beginning to go out sick. So why not institute masking at that time? We know better now, so we should do better. It is disappointing to me that we are at a point of closing schools in multiple states, in multiple cities, in multiple school districts, because we have not done what is necessary to protect our school communities. Probably most importantly, is that we have not committed ourselves to improving indoor air quality. I understand the barriers. It may be expensive, may make some noise, but if we are at the point of having to shut schools, I don't think any of these excuses hold any weight whatsoever. We had extremely vocal, loud contingents of people advocating to never close schools. Yet here we are closing schools, and I gotta say, I have not heard a peep from any of them. So I'm just pointing out some of the hypocrisy around all of this in the hopes that we will work to do better. And if we decide that it's just somehow inevitable that there's going to be times where we have outbreaks that necessitate closing schools, then let's at least be consistent. And let's do the same when we're having COVID outbreaks as well. Because when it comes to COVID, not only is it more contagious, not only can we spread it before we even have symptoms, but we can get it multiple times a year, unlike the flu typically. And it can cause long COVID. We know that multiple infections, repeat infections, can have a cumulative effect. We know that it is affecting the heart, it's affecting the lungs, it's affecting potentially multiple organs. And we're still learning about all of these impacts, including the nature of the cumulative impacts of repeat COVID infections. So definitely as it relates to our children, we should not be taking any chances. So on that note, just a few reminders. We should be improving indoor air quality by increasing ventilation and improving filtration. This would probably be the single most effective intervention to truly reduce the spread of these viruses that are transmitted by airborne particles. Definitely masking and reducing mixing and crowding would go a long way. Maybe you're someone or your loved ones or your kids have stopped regularly masking, but are still open to it in high-risk situation. So I think now would be a very good time to reconsider. Wear a high-quality filtration mask like an N95 or KN95. And this is to not only reduce your own risk of getting sick and your risk of getting others sick, but also just to do your part in the community, in your community. We don't want to see our schools having to close. We don't want to see our hospitals overrun. And I do think that most of us would rather be part of the solution than be part of the problem. So on that note, we will conclude today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.